Okay. So now let's transition a little bit. You already made the transition a little bit from the ED to the ICU and talk about the care of these type of patients in the ICU. At OHSU, this person would go to the CV-ICU, which you also work there, as well as the medical ICU. I think you've talked about the main stabilization of, the patient in the ED, but when that patient arrives to the CV-ICU, like what things do you want to ensure have happened in the ED and do you want to really follow up on when they hit the floor in the CV-ICU?
The things that we'll have to do immediately is talk to the patient or get some form of consent or some idea of what their goals of care is.
Okay.
This is a very high mortality, morbidity scenario. Nobody likes it. But this is a time to be very candid about what's realistic. And if we're going for cure, it's going to involve a lot of stuff.
Yeah.
And so if the ED didn't already have that conversation, we would definitely be having that. The other thing that we're going to need is, like I told you, arterial lines and arterial access almost immediately. And we have to ensure that we have adequate heart rate and blood pressure control, because the risk of actually short-term death goes up if you even allow for transient hypertension or tachycardia. And then the last thing we're going to really need and document is a neurological exam, because this actually does make a difference. If they did throw off, for example, a clot from a penetrating ulcer, for example, and they have an embolic stroke that's not due to the dissection, it's very tricky what to do about this.
Yeah.
What is the risk of hemorrhagic conversion when you're put on bypass and have really high heparin levels? Should we wait, knowing that the natural history of this is surely to lead to death? What's the risk-benefit ratio? There's no good answer to that. All of these things are very difficult.
So basically it's lining them up and making sure that they have all the appropriate lines that they need for the OR, making sure whatever drips and stuff we're starting the ED for blood pressure and heart rate control are adequate, and having a goals of care discussion and a good neuro exam.
Yep.
Okay. So let's talk about these patient goes to the OR and they come back to the CV-ICU. They've had their repair, say it went relatively well, and we're talking about the kind of progression of this patient in the CV-ICU into out of the ICU. When they come back from the OR, what things are important to you that happened in the OR, and then kind of what things are important to you moving along, looking at this patient's care.
This type of surgery is super fascinating and very complex. You can imagine, in order to fix the piping system for your entire body, you're going to actually have to clamp it off and stop blood flow to the entire body to pull this off. And the configuration for maintaining some degree of perfusion when they're trying to repair the pipes is really important. Some of the ways they protect the brain and the body and the heart during this is to make the patient very hypothermic. Other ways is they can do perfusion, say, to the gut by putting in a cannula here to pump blood backwards towards the gut. And sometimes they protect the brain by putting a cannula in the subclavian artery and then clamping it right at the innominate, so the blood flow from the subclavian bounces off the clamp and goes up the carotid and actually perfuses part of the brain. Of course, then you have to depend on an intact circle of Willis for make sure you have bihemispheric perfusion. So all these details are important. How long was the surgery? How long did you have your clamps on? How long was the hypothermic time? If they had to repair the valve or not? Were the coronaries torn off? Did you have to reattach them? You also have to think about what were they like coming off bypass? What was their heart function, right side, left side? How much inotropes pressure do they need coming off? How much blood products they needed? And once they're back in the CV-ICU, you're monitoring for all sorts of things that could go wrong. A lot of times it's rhythm, because if they mess with the aortic valve, you might be in complete heart block. You have to address that. A lot of them come out and they're still in hemorrhagic shock, because you can imagine the body does not like being on high doses of heparin and cooled at the same time. They're going to be bleeding a lot. Bleeding that proline is not going to fix, the type of bleeding that you have to fix medically through a lot of resuscitation with different types of blood products. The neuro exam is really important. It's something that we monitor as best as we can. They're all ventilated. They have drains everywhere, and they have a high risk of going into tamponade from an oozing intercostal or something like that. So there's a lot of things that we're still watching out for. It's usually still a very rocky course.
Yeah. So, I mean, obviously, you mentioned a lot of things you're watching out for. There can be a lot of complications just from the surgery itself, and from all the stuff that is done to the patient in the OR. Usually, when they come out, they are on a little bit of like pressor. Is this correct? And then also, what are your blood pressure goals for these patients as they progress along, and when are you able to like liberalize those blood pressure goals?
There's two different ways you have to think about this. There's a vasopressor, and then there's inotropes, and there's combinations thereof. Not infrequently, these patients need some inotropes coming out, because when you put the patient on bypass, or you cool the heart, or you stop the heart, you need a little bit of something to wake it back up. And that's where you use epi or milrinone or dobutamine or whatever you want to kind of stimulate the beta receptors in the heart. That's different than the vasopressors, which is vasopressin and norepinephrine, which we think work more on the arterioles and not the heart itself, and that generates a blood pressure. The blood pressure goals is, MAP above 65, but the systolic less than 120.
Yeah.
That goal is pretty tight, and maybe day 1, day 2, we will liberalize it to 130, and that's usually our operating principle going forward. That even though we fix the dissection flap both proximally and distally, so there shouldn't be much more extension, we still try pretty aggressive blood pressure control, keeping it less than 130, so that this doesn't happen again. A lot of these patients need a lot of agents.
Yeah. If it's a standard patient that actually does well, how quickly are you weaning off the inotrope support? Is it like 24, 48 hours? You feel comfortable kind of weaning that down? Is it trending coaxes to figure that out?
Yeah. Every institution does this one a little bit different. One of the sayings is that you're really trying to prevent the development of RV dysfunction or heart failure. And mostly we worry about the RV because it's most anterior, it's least cooled, it's most likely for an air embolism, all these different reasons, rather than to treat it. And so when the goal is to the prevention of something rather than the treatment of something, it becomes trickier how you wean it. So it kind of depends. It depends on a lot of variables, like what was their cardiac function when they went in and when they came out of bypass. Because if it was normal, you probably don't need inotropes. If it was dysfunctional, how bad was it, and how much inotropic support did you need to get them off bypass? So if the person comes out on 0.02 of epinephrine, you could probably get that off by day 2. If the person comes out on 0.1 of epinephrine, it's probably going to take you all week to safely bring that down without seeing cardiogenic shock and treating it, because you're trying to prevent it. That's a tricky part. You're not weaning, because you're using coaxes to measure the cardiac output, but I'm trying to tell you, by the time the cardiac output is down, it's actually harder to treat and much more emergent and more of a disaster.
Yeah.
So this is a complex topic. We look at a combination of cardiac output that we can measure by coax or thermodilution, but also like what is the venous pressure? Because one of the surrogates of heart failure is that your venous pressure starts to rise because you're not able to keep up with venous return. You also think about the renal function. How much urine are you making? All these other variables come into effect.
Okay. So I think this is something I didn't realize my first time in the CVICU, and I think you mentioned on it, is like, as people that aren't surgically trained, understanding as much as we can about what happened in the OR and all the support that anesthesia gave and how important that is in the care moving along in the ICU.
Yeah.
And just like really focusing on those details and getting a good report when they come out of the OR.
This whole thing's a huge relay race. You're passing the baton along as the ER physician to the surgeon. The surgeon will pass it to the anesthesia while they're working together, pass it on to the intensivist. It's a huge relay race.
And then in terms of things that you trend on a daily basis on these patients when they're in the CVICU, obviously, you're in an invasive monitored setting, so getting labs pretty frequently is not an issue. But are there specific things that you think are unique to these patients that you need to trend on a daily basis or even multiple times a day that you think is important? Or is it kind of just your standard labs that you're following along with?
There's nothing that's terribly standard about any of these patients because, again, they're so different. The nature of emergency medicine and intensive care medicine is supportive care. And supportive care means giving whatever the patient in front of you needs. It's really hard to generalize that to all patients. Speaking back to the whole population-based medicine versus individual medicine, Population-based medicine is saying, hey, look, I did this thing to everybody, and I'm getting an 80% success rate, and that's better than the previous thing that somebody else did to everybody and got a 70% success rate. And that's considered a success in population-based medicine. Phenomenal success, 80 versus 70, great. That's not a success to an individual clinician. We're all aspiring for a 100% success rate for every one of our patients. And so the question is, what regimen do you pick to have success 100% of the time? Doesn't exist. The question that you pose is, what strategy do I employ for picking an appropriate regimen that will be tailored to individual patients so that it can be closer to 100%? So rather than banking on one regimen, but you're banking on a strategy to pick an assortment of different regimens. And so that's where, it's going to be different. I can't answer that lab question because it depends.
Yeah.
Some people, they're Jehovah's Witness. You might want to minimize those labs. So you're going to purposefully start drawing like CBCs every third day because you're going to say, what am I going to do with a hemoglobin that's low anyways? I can't transfuse it.
Yeah.
Right? So, everything is tailored.
Okay.
If you know that this dissection goes down and is close to the celiac, you might be trending those LFTs multiple times a day because you might be really worried. Someone else where the dissection flaps nowhere close, you might say, yeah, I'm not going to look at the LFTs again. So it completely depends.
Okay. And then another thing I wanted to ask, so let's say our patient's gone through this gamut, they got surgery, they're ready to go to the floor. When you see these patients in the ICU and you're an ICU doc that also works in the ED, what pitfalls can you give us to ED residents or ED specific people that you would say kind of gets missed by the time they get to the ICU? Is there anything you see that happens over and over again that you kind of like to tell people and that work in the ED that we can improve upon?
That's a great question, and it's a question I ask myself every day, and the reason why I like working in these two environments. It's a constant learning process. I think one of the biggest pitfalls is, I guess people will describe it as anchoring bias, especially with the advent of the new troponins getting more and more sensitive. They are much less and less specific, and it's very easy for the emergency physician to see a patient who is in severe pain. The story is not classic for chest pain, but this physician read that the story doesn't matter anyways, and they get the gamut of tests, and one of which is a point-of-care troponin, and it's not negative. And that makes the disposition in this physician's mind very easy. It's a non-negative troponin. This is an NSTEMI, aspirin, call the cardiologist, put them in ED obs or medicine, and they could think about risk stratifying or cathing this patient later, as long as this person doesn't have a STEMI in front of me right now. And that's kind of the thought process, right? The thing is, though, that troponin can be elevated for any number of reasons. The percentage of troponin elevations as a result of plaque rupture, myocardial infarctions is getting smaller and smaller because our test is getting better and better. And so if you have a dissection that is stressing your body, your troponin might go up, right? And then that would cause the physicians to anchor bias onto MI, treat it as MI, and delay the whole process. Again, go back to your history and physical every single time and really think to yourself, yeah, the troponin's up, it's making me think MI. Does that make sense? Is it a plaque rupture MI or is it something else, right? Because it could still be something else. PEs can raise up your troponins. Dissections can certainly increase your troponins. So don't get anchored too early. And again, always go back to the physical. Harping back on this a little bit more, the exam is so important. It's super important. That the last couple of dissections I've caught were all from actually exam. And I wouldn't have thought to get the CTA without the exam. As you pointed out on the likelihood ratios, the neurological exam deficit, isn't it like a likelihood ratio of plus 33 or something like that?
Yeah, it's really big.
And the focal vascular pulse deficit is a plus likelihood ratio of 10 or 20 or something huge. Your patients aren't going to tell you, oh, by the way, I can't feel my radial pulse. They're not going to know. You actually have to look for it. And the last couple I found was my leg's cramping. It hurts real bad. It could be anything. It could be a whole load of nothing. Hey, I can't really feel this femoral pulse at all. I'm honestly looking. It's embarrassing. I can't find it, but you're talking to me, so you're not dead. Get the ultrasound. Here's the artery. There's no flow. That really makes me think, wow, something really wrong has happened now. There's the objective evidence I needed, even without chest pain, to think about dissection or an intraluminal clot. So the exam, really pay attention to it.
All right. Well, thank you so much, Rand. I don't know if there's any last thing you want to add, or any last thoughts you have about aortic dissection. Definitely a tricky diagnosis at all times, whether you're in the ED or in the ICU as well.
Yeah, it's very difficult because it's rare. There's a sense of stewardship involved. Like you don't want to CTA everybody, but there's not a good way to diagnose it without it.
Yeah. All right. Well, thank you so much for your thoughts and your insight. We really appreciate it.
No problem. My pleasure.